TopMedTalk.
I just remember some of the words that I heard from some of the Jan Stewart wellness lectures that the AANA does now. To remind us all, Jan Stewart was a former president of the American Association of Nurse Anesthetists and was a good friend of mine. And in 2002, she unfortunately had a fatal overdose of Sufenta. And her daughter, Sarah Stewart Gomes, has spoken to us many times now. One of the things the AANA did in response to that terrible event was they have put a wellness lecture on the AANA Congress. And what Sarah Stewart Gomes says is, over and over again, the message from her mom would be, we need to give each other permission to care for each other and to help each other. And I think that that's the big message from the AANA Health and Wellness Committee. We're not super people. You know, we think we are sometimes, but we're not. We're just human beings doing the best that we can. And we do an amazing job doing an amazing task and providing an amazing service for people, but we need help. And so I think we just need to give each other permission to reach out and help each other when we need help.
Chuck Griffiths there, the Assistant Clinical Professor at the UCLA School of Nursing Facility and the USC Doctor of Nurse Anesthesia Practice Program. He was speaking on TopMedTalk about the subject of suicide prevention. Nick Majerison here. Welcome to TopMedTalk. Today's TopMedTalk is on the subject of suicide prevention. And it's in light of the fact that today, the 10th of September, is World Suicide Prevention Day. For more details about that, you can check out our show notes, where we link to an article on the World Health Organization's website. We thought it was an important subject, and so we've decided to look at some of the content that we've done here on TopMedTalk around the issue of suicide. Alongside Chuck Griffiths, we have Fara Lekhnych, CRNA at the Johns Hopkins Hospital in Baltimore, and Catherine Horvath, CRNA, Assistant Professor and Program Director of the Doctor of Nursing Practice Nurse Anesthesiology track at Johns Hopkins School of Nursing, Baltimore. Have a listen as they discuss with Desiree Chappell the subject of suicide prevention. Don't forget, if you'd like to hear the fuller version of this conversation, check out our show notes where the link is available.
The AANA Health and Wellness Committee actually had a charge this year to look at suicide prevention for the profession. We'll talk about some of the reasons why, but that was our charge. And so as one of the activities that we engaged in as a committee, we put together a presentation part of the AANA meeting. It's entitled Suicide Prevention for Certified Registered Nurse Anesthetists and Student Registered Nurse Anesthetists. And basically what we did with the presentation, as you will hear when all of us talk, because we're going to kind of recap some of the major points that we covered, was we looked at the phenomenon and we looked at why it's important to us as healthcare providers. And we also looked at ways that we can help each other. We take care of the world, but we don't take care of ourselves. And so this is about that. It's about us taking care of ourselves and each other.
How prevalent is suicide within our tribe of CRNAs in anesthesia?
It's interesting that you ask that, because one of the problems currently that we face is that we haven't had any work done in the area of wellness and suicide for about 10 years. Our wonderful colleague, Anthony Chippis, and his colleagues about 10 years ago did a study of wellness in CRNAs and SRNAs, and part of what he looked at was suicide. And at that point, in the sample of students that he looked at, there was a considerable percentage of students that had admitted to suicidal ideation. All of us, every single one of us, have heard of CRNAs, practitioners committing suicide. When I was a chief CRNA and a program director, one of my former students who had become the president of the California Association of Nurse Anesthetists committed suicide. And I've lost numerous medical colleagues as well, anesthesiologists and anesthesia residents. So it's out there. It's a problem for us. And again, that was part of the reason why the board decided to give us this charge. And again, I think if anyone tunes into our presentation, looking at all these different aspects of this problem, you'll agree at the end of it, this is something we need to look at, and there are things that we can do.
Before we got started, you were telling me about a student that recently committed suicide, even in this last year, and two in 2019. We really are seeing that rate of suicide for our CRNA students?
Yes. In the last couple months, all of us got a report that there had been another student suicide. One of the onuses that really started the AANA board on this journey of coming to the Health and Wellness Committee and giving us this charge was a terrible situation that happened in the fall of 2018. 2 students in a program in the country got together and committed suicide together. And it was such a blow that it just really sent shockwaves through the entire profession. And the board came then at that point to us and to their committees and said, we need to do something about this. What can we do? One of the solutions that they had was to do research, which I volunteered to do, actually. I've taken it on, and we're going to do a national survey, just like our wonderful colleague Anthony Chiplis did 10 years ago. We're going to update that and get information. One of the other ways of approaching it was looking at the resources that we already had in our Health and Wellness Committee and in our Peer Assistance Committee and applying those to the problem of suicide. Again, in response to that, there was at least 2 more student suicides since that double suicide in 2018. Mm-hmm. It's just a charge that all of us have to respond to.
Kathy, anesthesia is a high-stress environment for a multitude of reasons. So tell us a little bit more about that. I know that was something that you presented on.
I mean, you're exactly right. Our lives in general are stressful at times. And then, we work in a very fast-paced, complex environment. So our work environments can be stressful. And, unfortunately, a lot of times we don't know that people are experiencing stress. It's not evident on their face. Risk factors for suicide, stress definitely is up there, along with mental health disorders. Depression and anxiety have definitely been associated with suicidal ideation and the act of suicide. Also, risk factors could be things like alcohol use or abuse, a history of past trauma or abuse, a history of physical illnesses or chronic illnesses that somebody's struggling with. People could have had a previous attempt before they became CRNAs or SRNAs. They could have had a family history. Somebody in their family has committed suicide. All of those could be kind of hidden to colleagues that are working with people, and they may not know of them. Also, risk factors could be a loss of a job or recent changes in finances. You could have a loss of a relationship that was valuable to you. Sometimes you feel isolated, or you just kind of have lack of social contact. We all feel that at times, right? Especially right now, right? We're all in front of our computers a lot, but we're missing that kind of, even though I may not hug you if I saw you, it's just seeing you in front of me gives me comfort. Yeah. And we're all missing that. Again, a lot of these risk factors can be hidden from kind of view. So we really have to look out for some of the warning signs of, kind of what to look for. And some of them can be as blatant as somebody talking or posting on social media that they want to die, or they want to kill themselves, or they want to harm themselves. It could be talking about kind of feeling isolated, feeling hopeless, feeling they have no purpose, or they're trapped in some situation they can't get out of. They could feel burdened by something. Then there's they eat too much or too little, they sleep too much or too little, they start using alcohol or drugs more frequently. Some of those are a little more outward and you can see them. And I think, when we start to see some of these warning signs, it's really important for us to recognize they're a warning sign. It may not be a warning sign that they're having suicidal thoughts or going to act out in any of those behaviors, but that we bring it to the forefront, that we're willing to kind of question somebody. Are you thinking about suicide? Are you thinking about harming yourself? Because a lot of times it's just, if somebody is questioned about it, they'll bring it up. They'll say, well, yes, I haven't been feeling well. And so I think it's just really important to kind of know that there are some risk factors and understand what some of those warning signs may be. We all feel down sometimes, but there's questioning how down are you? Are you having some of those feelings of harm or hurt?
A couple of things that you said really stuck out to me. One was the stigma, which I think all of us have recognized, that goes along with mental health diagnoses, mental health illness. And I think that that's part of the problem that we have in getting people to treat themselves and to open up to us and let us know when they have a serious problem, because there's a stigma associated with it. I think people get scared that if they admit that they're depressed, they admit that they're anxious, they admit maybe they've had a thought of suicide, they're going to lose their job, lose their position. If they're a student, they'll be sent to counseling and thrown out of the program. I think the other thing, we have access to very potent drugs, immediate access to them. And if we want to do ourselves in with using those drugs, we can do it very quickly and very easily because we know how to do it. And so, again, I think that that's part of the reason why we're having this presentation, because if people do get into the situation where they are starting to contemplate suicide, they can move very quickly to an effective means if they're in our profession.
Sometimes they say diagnosis is half the cure. A little while ago, TopMedTalk were proud to host a conversation with Andrea Bittinger, a CRNA at William Beaumont Hospital, on the subject of emotional intelligence.
And what I found, it had not been studied at all. There was no literature about emotional intelligence in certified registered nurse anesthetist. What I did find, what kept coming up, was emotional intelligence in nursing. And the majority of the literature had to do with stress and burnout. So that became my topic. I was going to do a springboard study on emotional intelligence in certified registered nurse anesthetist. So with the help of my great committee and the Michigan Association of Nurse Anesthetists, I was able to complete a descriptive study on assessing those levels.
So within the context of this conversation, for those people out there who may not be familiar with the term emotional intelligence, I'm guessing we all would make up our own version of what it means. What's your elevator pitch definition?
Well, I actually have my own definition, and it's the ability to perceive, integrate, understand, and utilize emotions in an effective and meaningful way in order to cope and adapt to the situation.
Fantastic. Yeah. Is that on Wikipedia yet? It should be.
I was going to say, at some point, I want people to Google search EI and the Bittinger definition will pop up. I figure it's a B. It might be the top one coming up. There's a lot of different definitions of it, and it depends on each individual who's defining it.
The context, I guess, of where it's coming from.
Psychologists have one way of looking at it. There's various psychologists that have been known to be famous for it.
So you'd guess to survive as a clinician, as a nurse, for example, that your EI would, to survive, to stick at the career long term, your EI would be high.
One, you would think, and there's a lot of different components of it. Mine was actually quite low when I got myself tested, and there were some aspects of it that were fascinatingly high and fascinatingly low. What's interesting, though, is if an individual was to have an emotional intelligence assessment, it's one of those, it's something that can be worked on and can be improved. You can be educated, you can be coached, you can improve it. Unlike IQ, which typically peaks in the high 20s, early 30s, your emotional intelligence can it can increase, but it can also decrease as your life goes on. So it's something that you can work on.
So a couple of quick examples. How does good EI, high EI scores manifest itself clinically, and what does bad look like?
Well,
the two ends of the spectrum.
Somebody that has high emotional intelligence, and I think about the operating room environment.
Yeah.
We don't have the ability to, when you talk about in the business world, if somebody's arguing with you or you're you can step out of the room and take a deep breath. Yeah. We can't do that in the operating room. They're focusing on the patient, but we can also be in some hostile situations. So having a higher level of emotional intelligence will, number one, allow you to be able to process really what's going on in the argument or the hostility or just the panic situation, and be able to, gather your thoughts, focus on the patient, and take care of the situation later on.
And if I wanted to try and determine my EI, is there a website I can go to and a little test I can do?
There are. Okay. However, the more readily available a test would be, the less robust and reliable it will be.
So you can't take one on Facebook.
Yeah.
So if I really want to know, how should I?
For the study that I used one that was 33 questions, and the publisher or the creator of the test, had it on the tool that I used, that it was out there and readily available. But it's not going to give you a very good description of your highs and your lows and what you can do. I mean, there's two of the most common assessments and most highly sought after assessments are it's called the Mesquite, and it's the Myers-Salivate-Caruso evaluation of emotional intelligence, and then there's the Multi-Health System 2.0. So you have to pay for them, though, and they are much more robust, and they will take some time. I know the EQI 2.0 is 133 questions, but it's a lot more precise on the various factors. Each test also looks at emotional intelligence in a different model of how EI is assessed and how individuals have the different components of it. So the one I got certified through is the Multi-Health EQI 2.0, and it's a fabulous assessment, and then the results are very readily available.
And you said that you were suggesting you should factor, which sounds it should be normal to factor it into interviewing any clinician for a job, possibly anyone for any job. But what's practical from that perspective? Can you do it at interview, or is it best to do a pre-test?
I think you could do both. The thing is, we have no data about nurse anesthesia and nurse anesthesia students as to which emotional intelligence components will make a student successful through a program, through the career. So I have to be cautious on just using that or even coming up with a way of assessing and making sure that this is a certain criteria based upon a score. Okay. What we do for our program at Oakland University Beaumont is we have one area of our interviews, one room that assesses their emotional intelligence. And we utilize situation-based questions which hone in on some of the key components that we at our program feel are essential for a student to be successful in our program. And we model that after the EQI 2.0 assessment of emotional intelligence, which is 15 different criteria, which is stress reduction, empathy. There's various factors. And so we as a faculty met and decided, the 5 most essential components for our program. And then we modeled questions or created questions based upon that.
And what are the 5?
Well, I can't reveal that.
Oh, you're not supposed to.
I cannot reveal that.
What are some of them?
We feel probably one of the biggest things is stress tolerance, the ability to tolerate stress.
That's for sure.
Flexibility is another one that we feel is very important.
So if someone wanted to get information, if they're interviewing for like Monty said, for anything in a job, where can you find a resource that kind of just talks you through some of those things? Because as you're saying, I'm like, oh, okay, how do I deal with stress? Or start to think about it a little bit more.
There are a lot of books out there. So I think, I was asked this question yesterday after I gave my talk, and I think you kind of have to maybe get on a website and look and see how the book reads, and if it's something that you like. I like the Stein book and Conoy, and they're, of course, because I was trained under the multi-health system, but it's a very easy book to read as far as how they describe the different emotional intelligence components. And they actually have examples of people that would have high EI in those categories or low, and then how you could go about improving them in situations that you might want to seek out so that you can improve your emotional intelligence. I think that's a great book. In fact, they have it's called the Student EQ Edge, and we advocate that our students read that before they come into the program so that they can kind of brush up or just realize that there's a certain skill set that's going to be essential for their success.
For sure. Oh, go ahead.
It struck me that is there any evidence to suggest the fact that people who want to understand more about their EI and who try and improve their EI have a higher EI?
You're going to ask something like that.
My hunch is it would be.
One would think. And I don't know that there's literature out there to prove that.
Let's find it out.
I can tell you, though, before I took the course, and there, like I said, my score was I wasn't real thrilled with it. And there were some areas where I knew that I was really bad in, and then some I was surprisingly high in. I would like to see myself assessed now because I know that the areas that I was low on, I've really tried to improve upon. I've tried to, I know one of them was flexibility, because I am totally not a flexible person as far as routines. I don't like to get out of my comfort zone. But knowing that, I have pushed myself to get out of my comfort zone, to try new things, to explore new possibilities, this being one of them.
That's good. Yeah, podcast sitting down with it.
Does that mean you sort of have a pause when something's happening? You have a little pause and say, I wonder if I'm just being inflexible here.
Correct.
Okay, I can see that.
Yeah. I do have to, be in touch with myself.
Away from the American Association of Nurse Anaesthetists, TopMedTalk has made a theme of tackling workplace stress and mental wellness, often called burnout. In this piece, we spoke with clinical psychologist Dr. Catherine Taylor about a report issued by the World Health Organization concerning arts and mental health. She writes a blog, Art Thou Well, which looks at this subject in detail. Here, a more clinical approach is being taken to art engagement as a means of achieving good mental health. Have a listen.
So social prescribing is the term that's used for this. Some people call it arts on prescription as well. And the idea is that a GP will be able to use what's known as a link worker, and that link worker will facilitate a link to a community group such as mother and baby singing. This, again, it's an option. It's one of the options that a clinician may offer. So antidepressants might still be offered, but people will also be able to choose between medicines and other evidence-based interventions such as singing groups.
So you'd get prescribed some arts?
Yeah, so there's a national social prescribing network in the UK, and that's exactly what it aims to do.
Social Prescribing Network. Mm-hmm. Do they have a website?
They do, yep, and I'm sure you'll provide that at the end.
All right, we'll pop that on the links. And then on a mechanistic level, how does this stuff work? Engaging with the arts, you know, if you take a pill, we know it raises your serotonin levels, you feel happier as a result. We're all quite comfortable with that. How does art engagement work to actually make the patient feel better?
So you're asking about mechanisms of action, causal roots. You've mentioned. Serotonin can increase mood. Engaging in a class or an arts intervention where you enjoy yourself and potentially achieve pride, sense of achievement, that has similar impacts on mood. There's a lot of research looking at inflammation, and so, for example, group drumming, which has been happening for thousands of years, group drumming can help regulate the heart rate, regulate breathing, help people to synchronize with each other, and that has quite profound impacts on the body's ability to heal itself. A great example that might answer your question, because obviously this extrapolates to different conditions and across the age span. Looking at premature babies on an ICU, so a neonatal intensive care unit, there's research that demonstrates babies who are exposed to live music or live lullabies, they tend to put on weight faster and are able to leave the hospital quicker. And if you think about what's underlying that, it's thought that that child is able to regulate its temperature and its breathing and all the things that the body has to do. It's enabled to do that by the release of stress that comes with listening to live music. So it's a lot to do with the detrimental impacts of stress on the body. If you can reduce some of them, then the body is better able to look after itself. We know that children who engage in the arts are more likely to go on to achieve academically, and there's plenty of evidence that shows that, you know, grey matter in the brain is changed through engaging with the arts. So, for example, playing music helps cognitive development. When you think about early childhood development, we use play, we use storytelling. Broadly, these are all forms of the arts, and they're critical to human functioning and can help boost belonging and social connectedness. So in the NICE guidelines, that's the National Institute for Clinical Excellence, there's numerous NICE guidelines that include recommendations for use of the arts. So, for example, for adults with psychosis or schizophrenia, there's ample evidence for NICE to include art therapy in their guidance. The guidance around dementia also recommends use of the arts for the reasons we've discussed. So if you think about the application of the arts as you are doing, we're talking about prevention, so enabling people to feel more connected to their peers, to their neighbours, which obviously supports health. We know that people who engage in the arts and culture for more than 2 hours a week tend to live healthier lives for longer. So there's longitudinal evidence from the Nordic countries that show people who engage in culture and the arts live longer. About half of that impact or half of that effect is down to things like socioeconomic status, education, where you live, but there is half of that effect that's independent, which is down to engaging with culture and the arts. So we've got prevention there. We've also got management of health conditions. So the advice that we give as a profession or as professionals, that can be supported by powerful messages from artists. And then thirdly, we have treatment. So treatment interventions can be augmented or improved through delivery of the arts.
Again, if you'd like to hear the fuller version of that conversation, please check out the show notes on TopMedTalk.com. Wrapping up today's piece, we're going to return to where we started. What advice did our guests give us about how to handle not just workplace stress, but suspected suicide ideation in a friend, student, or colleague? Have a listen.
In education, I've certainly had students that I have had concern for. And from a caring nature, I just bring them into my office and say, I care about you, so I'm going to question you. I'm going to question some of your behavior, maybe some of the things you're saying, just because I want to make sure you're okay. And if you're not okay, let's talk about, maybe some resources I can guide you to, or the counseling center on campus, or, other resources they can access. The AANA does have a health and wellness curriculum. It's tied to substance abuse, but the first part of that curriculum is health and wellness. Mm-hmm. So I know when they rolled that out, they encouraged programs, to adopt it or to use something like that. The Council on Accreditation for Nurse Anesthesia Programs requires there to be health and wellness curriculum. So you do have to talk to your students about that. And I think, a lot of programs have gone over and beyond that, in that they've implemented health and wellness activities in their programs. They try to support collaborative work and activities and play. They might do community service things together. There can be a student rep on the health and wellness committee, and sometimes they can bring back ideas about activities they can do in the program. There's also on the health and wellness website, there is a student side that gives tips that for students to stay healthy. It takes a village to sometimes keep everybody, in a good place. So I think it's just, again, recognizing that we all struggle at different times and just swooping in to help when you can. And I'm not a counselor, so I can't provide that kind of service, but I can certainly help them find it on campus. Yeah.
And I would think that a lot of this is similar to what we do in our for people who are practicing, so CRNAs. Mm-hmm. So Chuck, can you speak to that just a little bit about some of, Kathy had mentioned that depression is a major risk factor, and, anxiety and things like that. And, recognizing that our colleagues is one thing, but also, developing coping mechanisms and some of the things that we need to learn to be able to deal with this high stress environment, and then some of the propensity that we may have personally for things such as depression and things like that. So can you speak to that just a little bit?
I can. I wish that there had been training about coping mechanisms in programs earlier. As Kathy mentioned, the Council on Accreditation now requires programs to offer wellness information. Before that requirement came about, all of us were still learning as nurses and as professionals how to care for ourselves and each other. And we didn't have a really unified approach to it. And so one of my students could have benefited from that. She wound up committing suicide. And a lot of us knew, this is after she had graduated already and was a practicing professional. A lot of us knew she was a troubled person. And a lot of us reached out, but didn't know really how to reach out in an effective way, right, to offer her the assistance and the help that she needed to save her life. And I always go back to thinking about that person, a dear person to me, that maybe could have been saved if we had some of then what we now have more and more of now, which is ways to reach out and help people. Fara, talk a little bit about that for us.
Thanks, Chuck. Okay, so this is a big thing that we're dealing with, and sometimes when you do identify that someone may be suicidal, you think, I'm not a counselor, I've never dealt with this, what do I do? And so there's a method that is a proven training program. It was created by Paul Clinet. He's a clinical psychologist. He is the clinical assistant professor of the Department of Psychiatry and Behavioral Science at the University of Washington. He's basically an expert in suicide prevention. And his method is called PPR. So it stands for question, persuade, and refer. So you want to go to the person and you want to question them. You want to question them directly. Are you thinking of killing yourself? Are you suicidal? Do you want to die? Do you have a plan? And you have to be direct. It's kind of scary if, I ask direct questions, is that going to put that in your head? Well, thinking of ending your life is such a big decision. No one goes into that lightly. So you're not going to put that into their head. They've already thought about it. So the only way to really be able to effectively intervene is to question them directly. After you question them, and they might say, yeah, a lot of people actually, about 80 to 90% of those who end up completing suicide have already expressed it to at least one other person. They want to talk about it. They want help. So the next one, persuade. You want to persuade them to allow you to help them right then, right now. You don't want to leave them alone. You don't want to charge them with going to get help themselves. There's three main components to the mentality of somebody who is suicidal. So they're hopeless, they feel worthless, and they feel helpless. And so it's up to us to offer that help when they're feeling helpless. So referring them to the AANA, you can call together. Let's call now. Even if you need to get out of the OR, let's go after work. Let's go sit down for dinner. Let's call this number. You can call the National Suicide Prevention number, which is 1-800-273-TALK. 1-800-273-TALK. There are trained volunteers that they can talk to, and they can also refer them to local mental health resources. A lot of times there are emergency services, walk-in services that are available and free of cost, and they can help them find that. So very important to help them in the moment. The other thing is you need to have them make a contact. So a no suicide contract, those are very effective. So you say to the person, okay, let me help you. And while I'm helping you, let's make a contract because you're not going to kill yourself. Let's do this first. Let's call this number. Let's see if we can get you to see a counselor. Let's get you to this resource. And a lot of times they'll say, yeah, because they really do want the help. They're thinking about suicide because they don't think that there's help. And if you offer them help and you offer them hope, then that's one stepping stone to getting them to saving their life. And then the next one is you want to refer. Like we're talking about resources on AANA, if it's substance abuse, if it's depression, all different kinds of resources are on our AANA website. And you really want to take as much effort into actually helping the person. You don't want to give them a number and say, okay, here's what you need and go do it. A lot of times they really need for you to help them in a way that they feel like you care about them. Even if you share a story, hey, I may not know what you're going through, but I know it can be hard sometimes, and this is what helped me. And you want to listen to them. You want to have compassion. You want to be kind and patient and let them talk. And if they need to talk and you're just a listening ear, then sometimes that makes a huge difference.
That is such a great point. I've never heard it described like that before. It's QPR, is that what it is?
I just wanted to say, one of the things that I learned by taking the QPR training course, which anyone can take online, it only takes about an hour, was that many times people that are suicidal, they perceive that this problem in their life, this problem, is not solvable by any other means. And as Fara said, our job is to tell them there is another solution. You don't have to do it this way. There's another way to solve this problem, and I can help you figure that out. And I never really conceptualized suicide that way. I don't know how I thought about it, but it wasn't like that. So that helped me to really embrace the whole QPR approach to getting people help.
Fantastic point. Thank you so much.
TopMedTalk.
Thanks for downloading. Don't forget, of course, EdPom Chicago tomorrow. Make sure you check out edpom.org for more details. Don't forget to subscribe and link with us on any of our social media feeds, Twitter, Facebook, Instagram, and we've even got our own YouTube channel, TopMedTalk.com.